Mhm. Yes. Good afternoon, ladies and gentlemen. It's a great pleasure to talk to you remotely. It would have been a pleasure for me to attend this prestigious symposium. I'd like to thank the organizing committee for this invitation. I talked to you about sickle cell anemia burden on the health system. This is a disease that makes a threat to the patient, to the family, to the community, and to the health system. So let's see sickle cell anemia from this perspective to see how much we can do to help patients. Sickle cell anemia is a disease that normally causes occlusion of the blood vessel wall. It was always thought of as being mechanical obstruction of the blood vessel causing ischemia, and this was simply thought because sickle cell are in sickle shapes that are going to obstruct and they will not going to move smoothly. But it turns out to be a very much wider theory than what is thought. If you keep looking at sickle cell anemia as simple mechanical obstruction, you'll be looking from a keyhole to a very large bird's eye view like this. So you can only see a very small part of the disease if you keep looking in this way. Sickle cell anemia is a very complicated disease. It involves interaction between many factors, many integrins, adhesion molecule, VCAM, selectin, ICAM, and many of the receptors on the red cell wall that are activated or popped out the red cell membrane, and they will cause adhesion between the red cell and the endothelial cells. Uh, Adding to this, the fact that many of the integrins and the adhesion molecule will be bound to the white cells, and then the white cells will be bound to the T-selectin and E-selectin of the endothelial cell wall. And all this complicated picture telling you that it is a very complicated mechanism that causes adhesion of the red cell and obstruction of the blood vessel wall. Uh, Sickle cell anemia is a multisystemic disease due to single gene mutation. It's a very simple gene mutation of deletion and insertion of one simple base causing major complications of sickle cell disease, infections, anemia, painful crisis, stroke, gallstones, acute chest syndrome, renal failure, and pulmonary hypertension, as well as renal failure and other complications. So you can see it's a very wide spectrum of complications caused by single gene mutation. Disease started in Africa, spread to the part of the Arabian Peninsula, to the southern part of Europe, and to parts of China and India. And all this was due to the fact that traders in the ancient times followed what is called the frankincense tree, frankincense road, because this tree produced this frankincense, and this was sold to the temples in China and India and in the southern part of Europe, and this why it was truly called the frankincense road. Traders from Africa crossed the sea to reach the Arabian Peninsula, and they will travel from Saudi Arabia, from Arabian Peninsula to the east and to the southern part of Europe through these trade routes. And on the trade route, they spread the gene to these areas because they keep mating with individuals from other communities. In Saudi Arabia, you can see the spread of the disease mainly in the eastern province of Saudi Arabia and to the southern part of Saudi Arabia, where the gene frequency sometimes is 0.11, which is very high gene frequency, as if we are telling you that in every 1,000 individuals, there are 110 individuals who are carrying the gene. So this follows with a smaller number in other parts, and it's highest in the eastern province and the southern province of Saudi Arabia. About 145 individuals per 1,000 have the gene of sickle cell, and here it's about 110 per 1,000 carrying the gene. Sickle cell anemia is an autosomal recessive genetic disorder expressed as either homozygous due to 2 copies of the mutant hemoglobin S or heterozygous where it's a carrier state. In the heterozygous type, sorry, it's not showing. Sickle cell anemia is a substitution that creates hydrophobic region on the outside of the protein structure, and the globin is a molecule that will be always expelled from the other globin molecule by the power of the hydrophilic power of the molecule, bringing the water between each molecule and the other. In sickle cell anemia, we lose this feature. That means every globin molecule becomes hydrophobic. It will expel the water. If it expels the water from the outside, it means the molecule will be attached to each other and they will be forming crystalline structures that look like needle. These are globin molecules that are attached to each other because of the hydrophobicity of the molecule and causing needle-like structure that will sometime, and this is an electron microscopy of the sickle cells, where the needles of the globin molecules will rupture the cell membrane and will cause the changes that will allow the integrin and adhesion molecule to be apparent on the cell surface. To see how much this will be a problem, in a normal individual red cell, you will see that the epitopes or the antigens are hidden or embedded in the red cell membrane. If you uh, form hemoglobin polymers that are needle-like or elongated globin crystals, they are going to push the red cell membrane to both sides, and this will cause flipping of the phospholipid, and the molecules will be apparent on the cell surface. They're like budding flower in the desert. They're going to be expelled outside the red cell membrane, and if these membrane or antigens are expelled, they will be allowing adhesion to the red cell between the red cell and the endothelial system. Now, the burden on the health system is very simply adults aged between 18 to 44 accounts for 66% of hospitalization, 3 emergency department visits per year, and emergency visits rated with average 200,000 visits per year. About 20 to 30% of children with sickle cell disease experience stroke and cognitive impairment, and it accounts for 23% of pediatric stroke among the African American. Due to frequent pet crisis, children with sickle cell miss an average of 18 days of school each year. So you can imagine how much this will put a burden on the community and on the individual and their families. The cost of the treatment is in total, it's about 200 billions annually global number. The total hospital cost for hospitalization is in the range of $488 million, and the healthcare cost is about 1,400 per month for each patient. And the annual cost for children from 0 to 9 years is about $10,700, and for patients who are between 30 and 39, it's in the range of $34,000. In Saudi Arabia, the average total lifetime healthcare cost was estimated to be $1 million per patient. The annual cost ranging from $10,000 to $30,000 per an adult, and about total of $600 million total expenditure annually to treat patients with sickle cell anemia. In Saudi Arabia, we have the pre-marital screening program, which is showing an estimate carrier per million of 4%, 4.2%. That means 4.2% in the Saudi population carrying the gene. An estimated patient about more than 60,000 patients, and that is only 0.26% of the population of our country. The highest prevalence in the eastern and the southern region is the highest among all the Saudi regions. The pain is the most devastating symptoms, and we all know that 55% report pain in at least 51% of their days. 29% of patients reported pain at least in 96% of their days. So there will be always a minimal amount of pain in most of the patients for most of their time of the year. The iceberg model of sickle cell, majority of the pain experienced by the patient is not observed by the healthcare providers. That means patient may be having pain without notifying the healthcare professionals because they got used to it, and we don't see the real picture of pain in those patients as healthcare practitioners. The preventive measure cost is additional cost, and it's part of the cost of treating. It includes the newborn screening, penicillin prophylaxis, pneumococcal vaccines and other vaccinations, radiological screening, therapeutic transfusion, and iron chelation and hydroxyurea treatment. Those are additional costs to the treatment, and the treatment contribution to the burden is laboratory testing, medication, transfusion, bone marrow transplant, and gene therapy when it's available. Uh, to manage the pain of sickle cell anemia, we have three modalities: the pain medication, which are known to you, the analgesics, with all their types, and then we have the saline hydration, and that increase the volume of the blood. And mind you that many of the patients with overhydration may suffer from reduced pharmacokinetics of the drug that you're given, because if you're giving a normal blood volume, your medicine is going to act in a way. But if you overhydrate the patient, you need more medicine, and that add to the burden itself. Oxygen therapy sometimes help because it will increase the delivery of oxygen to tissues. Now, the ongoing trials that are there, or the treatment or the medication that are in the active pipelines, include L-glutamine. It's there now in the market. I put red arrows to show which medications are in the market. Glutamine is marketed widely now. Crizanlizumab got an FDA approval in our country and many other countries, and it's available now. Of course, rivapansel was stopped because of the side effects. Heparin treatment was one day used, and which was low molecular weight heparin, particularly tinzaparin, in clinical trial that we have conducted earlier in our country. Now, also the GBT, voxelotor, now is marketed widely in Saudi Arabia. So we have three active medication being marketed recently, and I am sure that these will be replacing soon the standard hydroxyurea treatment, even though we have seen benefits. Voxelotor and rivapansel and L-glutamine, those are three actively marketed medication for Saudi Arabia. Of course, hydroxyurea had an S-phase specific chemotherapeutic agent. Its efficacy reduced complication transfusion requirement, improved survival, and short-term safety, teratogenicity, carcinogenesis, and reduced fertility. Those are remarkable points to draw attention to. We are using chemotherapeutic agent, which is used in malignancy to treat a benign condition. So I think it's time to think of the alternatives to hydroxyurea and to explore the possibility with your patient to give them a better chance. For example, crizanlizumab, which is now available, it will reduce the leukocyte adhesion by blocking the selectin adhesion. In particularly, it's a monoclonal antibody against selectin adhesion, so it's going to help very much the adhesion between the leukocyte, the red cells, and the endothelial cells. Bone marrow transplant shows 85 to 90% long-term survival. We need a matched donor, and this is available in 15% of cases. One has to be very careful in selecting the candidates for the transfusion because of the known complication. A newer approach includes the gene therapy or inducing fetal hemoglobin, and this globin structure manipulation downregulates the beta globin gene expression. And of course, the gene editing procedures using zinc finger nucleosomes, and this is another possibility in the pipeline. There are some challenges with sickle cell anemia. I'm going to explore with you the top 10 challenges that we encounter when dealing with cases of sickle cell anemia. The first challenge is the pain intensity versus the pain behavior. Doctors and nurses need to assess the pain intensity as less than the patient assessment. We, as practitioners, will not feel what the patient feels. We need to be more sympathetic, try to understand what the patient feels. Pain behavior correlates weakly with the patient pain score, and the less analgesic due to the fear of addiction, iatrogenic addiction, hardly ever occurs in usual hospital patients. And of course, we know that all the patients will need aggressive analgesics, but we tend to give them less than what they require because of the fear of the addiction. We should not have this problem because this is sometimes will give the patient a worse opportunity to be cured. We have always the pain versus the pseudo addiction. If we choose between pain and pseudo addiction, I think one will be inclined to accept the fact pseudo addiction may occur, but pain is much, much worse than pseudo addiction. So this inadequate pain management will lead to abnormal behavior development in the patient, escalation of the analgesic demand by the patient, and crisis of mistrust between the patient and the healthcare provider. Again, it's a multisystemic disease. It is not simply pain. Patient with sickle cell anemia will be like patients with multisystemic disease. For example, patient with systemic lupus would have one antibody but damages all over the body. Same thing for sickle cell anemia. A patient with sickle cell anemia can have gallstones, iron overload, leg ulcers, infection, priapism, hepatopathy, acute chest syndrome, hip necrosis, and osteomyelitis, delayed puberty, and venous thromboembolism. Those are all the problems that we can encounter, and they really consider to be a great challenge for healthcare providers. Number three is to ask ourselves the question, who takes care? Is it a team of doctors? Is it the solo effort of the hematologist? And ideally, it should be a team of doctors and nurses, psychologists, social workers, and patient advocacy group. It is a community responsibility and hospital responsibility. It's much wider than just a hematologist effort. Again, another challenge is the financial challenge. We know that the healthcare cost was estimated for a lifetime of a patient to be 1 million. There is no definite rule who will cover the cost. In different countries, in different situations, you will be seeing different payers, either the government hospital, is it the insurance, or the patient is paying for himself, or is he treated under charity. So the financial challenge is a great problem for us. Five, education and awareness among the physician. The American Society of Hematology reports in 2016 it's only 20.4% of the family physician felt comfortable dealing with people with sickle cell anemia, and 72% of family physicians believed that more education and clinical support is needed for them to look after this complicated problem. Number six is the compliance. Compliance problem is there. You need to give if you are giving the patient hydroxyurea, you can expect neutropenia, fertility problem, and risk of fertility risk. And if you give folic acid, you will see that the patient is very compliant on the folic acid and the hydroxyurea, but there is no compliance on chelation therapy. Patients are giving chelation therapy if they have iron overload, but rarely they will be compliant. And vitamin D, zinc, penicillin, immunization, antioxidant, all of these important measures of treatment may be suffering from lack of compliance from the patient side. Number seven is acceptance and accommodation of the patients. Patients may be accommodated by the family most, but at school, because of their frequent absence, they are not very much welcome. At work, they are sometimes being fired because of the lack of presence on time, and in the society they may be expelled sometime because of the problem of the addiction. So patient with sickle cell anemia suffers from a big challenge which is being accepted by other, whether in the school, at work, or society, or in the hospital themselves. So this is a great challenge for the patients. Rejection at the treatment facility. Patients who are treated for sickle cell anemia are frequent visitors of the emergency room. The doctors and nurses seems to be judgmental for patients. They judge the patient as addict or not addict, or frequency of visits correlates with the intolerance. So a patient, if they feel that they are not tolerated and welcome to be treated in a particular center, they may feel rejected and they may stop coming to this center, and then they will suffer more from complications. Number nine is the special situation in sickle cell anemia. If the sickler becomes pregnant, this is a threat. If the patient is lactating, this is another difficulty. COVID-19 now has become a real problem because in addition to all of this, we know that sickle cell anemia is a state of abnormality in the immune system. So the COVID-19 is a special threat for them, and other comorbidities, whatever they are additional risk to those patients. Number 10 is the perioperative care. If the patient requires surgery, we need a hemoglobin of 9 grams. This should require transfusion if it's less than 9. Normally, more than 9 is adequate to perform surgery, and this is simply because of the fact that sickle hemoglobin carries and delivers oxygen more efficiently than our normal hemoglobin A. So we should accept the figure of 9 grams acceptable for sickle cell. And sometimes you will face difficulty convincing the anesthetist that this is the case. If surgery is a life-threatening and urgent, it should be performed, and the blood transfusion top-up or exchange can be given intraoperatively or postoperatively. Clear perioperative policy should be written in all hospital policies book, and it should be part of the practice in any hospital. To face the challenges that I mentioned, we need to input great emphasis on the premarital screening and awareness program. We need to educate every couple that they have to have sickle cell and other hemoglobinopathies tested before marriage. Newborn screening is a very important step because it is, to me, much more important than premarital screening to manage daily fatigue and cognitive effect. Long-term progressive damage of sickle cell anemia has to be given an education to the community, holistic approach to treatment involving many members of the medical teams, not only solo hematologists. Antimicrobial prophylaxis, vaccination, training of the healthcare worker is important for giving appropriate treatment. Encourage research that would focus on solution to improve the quality of life, address the concern about the ill-equipped provider, try to educate the healthcare provider in looking after patients with sickle cell anemia. And this was my final slide. I would like to thank you very much and thank the organizers of this prestigious symposium. Thank you very much.